beyond conventions. That is the thing. We are going to narrate a case of acute gastroenteritis, circulatory shock, and respiratory failure, and the importance of groaning in the management of this patient of acute hypoxemic failure. Basically, it is already proved beyond doubt with ARDS, but we want to stress the fact that beyond ARDS, groaning can also be very useful. So this was a 28-year-old female. She had no significant past medical history, and she presented to our emergency department with these complaints, basically gastroenteritis kind of symptoms, with fever in the last 24 hours. On 14/6/24, she presented with GCS, basically E4V5M6, but she was anxious and restless, and she was hypotensive. As you can see, BP was 70/40, pulse rate was high, septic shock index, basically shock index was 1.8, which is severe shock. So she also had a little bit of hypoxemia. She required oxygen to keep the saturation levels at 94 to 96% SpO2, and her respiratory rate was also a little bit on the higher side. She was mildly tachycardic. Also, excessive muscle use was there. At this time, the ABG, you can see, was going to metabolic acidosis with significant lactate was also increased. And initially, in the emergency, she received 30 ml per kg bolus, which is as per protocol, as per the sepsis bundle, as we see, and she was taken on noradrenaline infusion. This was her presenting, at the time of presentation, the X-ray taken showed, some of you may see a little bit of patch on the right side, but more or less the X-ray was okay. We would say that there were no overtly signs of any pneumonia or anything like that. And shifted to ICU, sepsis bundle care was initiated. Acute circulatory failure, that's basically had a hypovolemic circulatory failure kind of a situation here. But also sepsis could be another reason, and we hadn't ruled out cardiogenic shock till then. So we assessed the IBC of this patient. As you can see, it was collapsible, and the distensibility index was also normal. Basically, it showed that the patient was not fluid overloaded. So basically, at that time, we gave a guided fluid of around 120 ml per hour, alternating RL with LS. Broad spectrum antibiotics were started. Invasive lines were taken for monitoring and also for fluid and inotropes. Appropriate blood cultures were also sent. Serial lactate profiling was done, and with this fluid and ancillary treatment, she seemed to be improving. The lactate profile got better. As you can see, hourly assessment was showing that she was getting better. So this was the first R1B which we followed, which basically contains these 5 things. We use fluids, 30 ml bolus, crystalloid, 30 ml per kg, and also vasopressors, also antibiotic broad spectrum were instated, cultures were sent, and also lactate levels were measured. This is as per the surviving sepsis guidelines. So again, reassessment showed that her IBC was remaining the same. So we made sure that we didn't fluid overload her, because this was a situation that we were already, and you can see even in, this is the best possible window at that time we got. This is basically not an optimal window to see, but in the subcostal region, when we did the ultrasound, you can see that the ventricles are almost kissing. That means that she was not fluid overloaded at the time. So on day 2, basically there was respiratory failure ensued, and so tachypnea worsened. She got around 40, more than 40 respiratory rate. We took her on non-invasive, that is HFNC we had, and alternately non-invasive by ventilator was on, NIV was also given. And the oxygen requirement was increased to achieve the SpO2 to 90%. Earlier at 94, 95 with 2 liters, but now with the FiO2 requirement increased, and the PF ratio, as we call it, the PO to FiO2 ratio was less than 100. Also, along with it, the sensorium of the patient was slightly deteriorating. She was getting a bit drowsy. This was the ABG, which you can see. It showed basically hypoxia was there with FiO2 of 26. PO to FiO2 ratio was decreasing. It was around 50. So patient was intubated and initiated on non-protective ventilation, and persistent noradrenal requirement was there. And also the initial settings were low volume, which we use, tidal volume 400, and also respiratory rate of 20 with FiO2 100%, which was tapered gradually, but only up to 80% because beyond that she was desaturating more than 90, I mean less than 90. Also the peak was kept around 6. So it was increased to match the requirements up to 12. Day 4, that is after 48 hours of mechanical ventilation, you can see the patient responded to the therapy and she got clinically better. She was conscious, she was fully alert. So we gave this, after the spontaneous awakening trial, we understood that the patient was capable of following commands and we gave him spontaneous breathing trial. And after that, because the weighing indices were acceptable, so we decided to extubate the patient and kept her on watchful vigilance with NIV support. ABG post extubation was as follows. Lactate had normalized, she was having almost near normal pH, and oxygenation also improved. Now, on day 5, it was around 16-17 hours post extubation. The patient had again fever spikes and also new onset tachypnea, worsening of the respiratory failure despite the optimized NIV settings. Earlier she was comfortable, but gradually she became dyspneic and also tachypnea ensued. Also the PF ratio again dropped down to less than 150. We tell you the significance later on, those of you who are not initiated. And furosemide trial, we also considered the possibility that we might have overloaded the patient. So pulmonary edema might be the cause. So we gave her some furosemide trial, but it was not helpful. And patient was re-intubated basically in view of decompensated respiratory failure. Antibiotics were escalated to vancomycin was added actually as a hospital-acquired maybe a MRSA cover to be given. We checked the cultures again, and increasing vasopressor support was also observed. Now this was the X-ray at that time of the intubation. Here you can make out that there were patchy infiltrates all around both the lung fields, and here I would want your opinion based on whatever we have seen in the case. I would want your valuable opinion on what would you have done, sir and ma'am. What should we have done? Like what would have been your approach to treatment of this patient? Just anybody could provide any insights? Yes, sir.
Before you ask us, we would like to know how much time she required to get reintubated and what was the X-ray test before extubation.
Okay, sir, X-ray test before extubation, we could not actually, that was not included, but her chest X-ray did not show infiltrates. It was the same as before. Initially, she was intubated and within 48 hours, we gave the patient mechanical ventilation. And we tried the weaning trial if all the criteria were met, and she did not have any other GCS also. The main reason for intubating at that time was worsening GCS, which came better. Oxygenation improved. There was no patch as such in the X-ray, so we extubated.
So patient had back visit.
It's a possibility, sir, but it was loaded both bilaterally this way within 24 hours.
So how much time it took before you reintubated?
For 16 hours.
16 hours.
Yeah. Actually, this patient, we also thought that this patient is not going to respond so fast. Because when we saw this patient, the PF ratio was so bad that normally these cases they need aggressive ventilation for a couple of days. In fact, this response which happened in 48 hours was something which was not anticipated. But given the fact, it's a protocol for ICU that if you have acceptable acid-base gas clinical parameters, daily you should consider for spontaneous awakening and breathing trial. So we did the trial objectively and the patient passed. And just to add, sir, as you have asked, the patient was having relatively normal lung fields. It was not normal exactly as you have seen the first one. There was some ground glassing, but the PF ratio was pretty acceptable. And for 60 minutes, she sustained your SBD trial on pressure support of 6. So that was the thing. Now, the reason why we are saying, because when you have in this situation, what differently anybody could have done in this case? So this is what we wanted to know the opinion from you, sir. Dr. Bilyani, what do you think, sir?
What are the initial antibiotics here?
So this patient was started on beta-lactam and DLI, normally piperacillin desomactam, which was escalated to carbapenems, and then MRSA vancomycin also was escalated.
It's there any feature of ARDS in this patient?
This is what I want to know from you. What do you think?
Biochemically, and second X-ray is either a VAP or it may be patient had some previous illness which is going into ARDS category.
Thank you, sir. So you eased out my discomfort. Can you just go to the next slide, please? So what we did, we wanted to confirm that are we dealing with something just beyond the pulmonary edema, routine conventional pulmonary edema. So Dr. Ankit and Dr. Abhinandan, they did the lung ultrasound. We followed the blue protocol, and we discovered that this patient was having a just subpleural consolidation. It was not having a fractal sign. It was not having any dynamic static air bronchograms, just a subpleural consolidation. And if you can see there, bilateral B-tail, your comital artifacts, which basically indicates that the patient is having a lung congestion as main reason, right? So we did the basic echo assessment, which was suggestive of normal cardiac function as well, right? On the basis of this, we were not very clear, Dr. Sharma, whether it is actually ARDS, because it was more suggestive of congestion rather than obvious bronchograms which can lead to ARDS. Yeah, please, sir.
Was there an indication for giving any of those H1N1 type of antivirals?
So we were not anticipating, to be very frank. We missed on the H1N1 treatment, but you have a very valid point. Retrospectively, we thought maybe it's a viral pneumonia because of this H1N1 and maybe any other, the viral-like illness, because this was a retrospective diagnosis for us.
Because our GPs working in the private sector, they are very rapid in starting
Oseltamivir.
Yeah.
No, you're right. Actually, this patient came in June. This was on 14 June. I was not anticipating that at that time, we are now seeing more viral. So basically, on the basis of the pattern of the cases which we witness in our ICU, we take empirical decision. So at that time, we never thought that this is actually truly a viral. We basically thought 30 mils per kg patient has received. Plus, she continued on liberal amount of IV fluids. So we thought maybe the patient is having just a congestion to begin with. So what is next?
This report, ultrasound focus,
Yeah, ma'am.
has been given by the radiologist.
No, ma'am. ICU based, the focus has to be done by intensivist.
Can any radiologist comment on it?
Do we have radiologists? Do they do lung ultrasound now? Radiologists? Because as per my understanding, they are not doing lung ultrasound.
They do in babies.
Actually, they do it babies, they don't do it in adults. Maybe we don't allow them.
Why we take it that you are really competent in doing lung?
Yes, sir. We are comfortable, ma'am.
Because normally we say more than or equal to 3 comet lines.
You're right, ma'am.
So I cannot exactly make out that, and even the subpleural consolidation I'm not able to make out. That's why I asked you.
So subpleural consolidation, if you see, ma'am, this one, can you see this? Here it is coming. Unfortunately, we never thought we are going to present this case, so we are not having a library of videos and all. But I do have a series of cases. But the point here is that, if you see in typically a viral pneumonia, their consolidation are just subpleural location. So this was something which was there, but unfortunately I don't have the good videos with us. So what we did next, Abhi?
These are the best possible differentials that we considered. Like ARDS, as sir said, it could be a viral pneumonitis, there's a possibility, and it could be hydrostatic pulmonary edema, which the patient was receiving so much of fluid, 30 mils in the emergency, and also we were getting around 120 ml per hour. And maybe there was a chance that even though our focus proved otherwise, we were always keeping the degree of a cardiogenic pulmonary edema. And also, overlap is always a possibility. So we cannot be pinpointing one diagnosis and we cannot be actually narrowed down to one. But still, she had elements of whatever, all these 3. Because sepsis was always there and we were thinking that we would have some points in favor of ARDS. We considered, because it was acute onset, as you saw, as you also with 24 to 48 hours, she developed this kind of a condition. Bilateral infiltrates in the X-ray we could find. Also the PF ratio was much less than 100, where severe hypoxemia was there. Cardiac dysfunction, according to our focus and whatever we have shown you, there was not any obvious cardiac dysfunction, not at least any regional wall motion abnormality, etc. And no collapse, no consolidation per se, or effusion, and also no atelectasis. But there were also points against, because we did not find any evidence of dynamic air bronchograms, anything in the subpleural, except subpleural consolidation which we saw. Also, throughout the ventilated period, a lung compliance was not very bad. It was always optimal, a little bit maybe deranged. And peak ever pressures, well, as you can see, they were only 24. Climatic pressure was only 18 to 20, and driving pressures were around 10 centimeter over.
Generally, just one point. Anytime chest CT were done on 4th day or 5th day, just before
So
extubation.
due to hemodynamic instability, we were always planning. Yes, sir.
Chest CT could not be done.
No, sir, I won't say could not be done. We never thought this patient is going to fail after the extubation. We thought the patient has such a dramatic response to the diuretics. And normally, the lung ultrasound which we do bedside, they gives you equally sensitive, the representation of the lung disease. So we never thought this patient has to be scanned, especially with the precarious, the PF ratio, risk of de-recruitment, and how the CCD happens in our hospital. We are privileged to have so many SRs with us. So that is okay.
Why I'm saying 4th day she was fine, she was extubated. And next day, 5th day she was again on ventilator.
Yes, sir.
So maybe she had some evidence of lung infection or maybe consultation.
Done, sir. I agree with you. I agree with you, sir.
The ICU films are not very good quality.
Yeah.
So I missed. And then again, on day 5, she again deteriorated and required intubation.
Right. I agree with you, sir. There is no doubt that's something we have missed. I completely agree with
I'll tell you
you.
what,
Yeah, please.
there is a number of sinister viral infections going on in our country.
Right.
So whether it is a COVID thing going on, a variant of COVID, mutation of COVID, H1N1, what all is going on.
Right.
We must take that into consideration.
No, definitely, sir. We are wiser by your thoughts. So, what we did in that situation?
Sir, another point, you said ultrasound gives you a positive finding. For the residents, ultrasound only gives you the negative from which you make up your diagnosis. Yes, it could be that. It never gives you a positive finding. It is a negative finding which we say that it could be this, it could be that, A line, B line, B, all those things. It's the other way around.
So, with due respect to you, sir, as far as the ultrasonography, because I'm a certified focus intensivist, the reason I'm telling you, now even ARDS 2023 definition has included ultrasonography bedside focus as the method of your diagnosis. This has become so sensitive now. Maybe we are from different very specialties, we have different exposure and different inclination. But to be very frank, we love ultrasound. We just
Even we also do ultrasound.
and it is sensitive, sir, for us.
If we had done a serial ultrasound at least once daily, then we could have made
Yes,
out
ma'am, I agree.
whether it was going
I agree with you.
towards pneumonia or was it an ARDS.
Yeah.
So since we don't have that and we have that single thing, it's difficult.
I agree with you, ma'am. There's some reckoning to the case, definitely.
In NICU we do ultrasound lung score, A line, B line, all those things are being
So
done.
you're throwing difficult questions on me.
Maybe we are
Allow me. No, what you are saying is perfect. We are also trying to do. Trust me, sir. Dr. Sharma has given us the ultrasound machine. We are doing it. Wherever we have a diagnostic dilemma or to assess a patient who is not having a predictable response, they will be specifically used.
And lung USG is better than X-ray.
Yes, ma'am. Even with CT, ma'am, I am not comfortable with CT
Even
because
better
I
than
need to
CT
respond
also.
Yeah. So, as a rescue therapy, what you did when the PF was so less?
Sir, as we all are agreeing to disagree and so many matters, at that time the patient's life was at stake, so we could not afford to have a debate anymore. So as a rescue therapy, we decided to prone because there were some points in favor of ARDS, some points in not, and it was costing to the patient. So as a rescue, we thought, okay, let's go ahead with proning. Ankit sir was there, he took the lead basically in deciding, and we decided to prone the patient. And remarkably, lung protected ventilation was always continuing at all times. And there was a dramatic response to this prone ventilation within 24 hours, sir. Basically, we did a total of 5 cycles over a period of 5 days, 16 to 17 hours per day. We were doing it on the lines of the recommendations by Proseva. So the PF ratio, you can see it improved from 60 to 200. That is a remarkable, that gave us the onus to continue it. First day, second day, third day, basically we saw gradual improvement, and that helped us on that we are on the right track. Basically, it was the outcome which was deciding what path we should follow in this patient. On day 8, that is after 5 days of proning, it came to more than 300, and the patient was becoming clinically better. She was basically fully conscious, she was responding. Chest X-ray, the things were more or less clear now again. this was like something we had not anticipated. We were thinking as a rescue therapy, but it proved to be basically therapeutic for her. And vasopressor support was also gradually weaned off. So many antibiotics were also working in that way that the sepsis was also reduced. And plus, of course, we all know that prone ventilation, if done correctly with blood pressure, it will only help the circulation, not immediately. Now, conservative fluid therapy and all. So basically, after taking her out of the ventilator, we continued with the NIV support and HFNC, and basically, patient was successfully weaned off. And I would like to give credit to our physiotherapy team. This is Dr. Vivek, is our lead physiotherapist there, is giving round-the-clock services, and his team and basically with the nurses and all, nursing care is also of utmost importance. As you can see, the patient got better, and she was eventually discharged after a few days post-extubation. So here I want to tell you that proning, basically we have been using it in the ICU.
You know what I like, sorry to interrupt.
Sir.
During the COVID days, I was doing medical
Very well known.
and Dr. Rao,
is only treatment
we gave a protocol.
Yes,
There
yes,
is
sir.
a protocol
Yes,
for
sir.
all COVID patients
Yes,
to
sir.
be prone.
Yes, sir. We are coming to that, sir. That is what it was a norm that obviously, sir, आपने भी देखा होगा. Everybody has seen that COVID, all patients with hypoxemia were prone, and that is what was a norm. But in this case, there was a gray area. We were not sure, and nowhere there are recommendations कि सिर्फ hypoxemia के लिए patient को. There are studies, as sir will elucidate later, but whatever at that time we were really confused whether we should go ahead with this diagnosis or not. We did the proning, and thankfully the patient improved. That is what we wanted to present. Now, regarding proning, I will just add a few lines before I hand it over to sir. Basically, it is an art of proning. So it has been now increasingly being used in all ICUs globally, which has revolutionized the treatment of ARDS and the outcome. So it is necessary for each one of us to understand, because sometimes we will encounter it. Some people are not initiated. Our motive was to tell us about proning basically, and how it helps, what is the physiology, and what are the concerns when one's the prone patient, and what are the precautions that we need to take. So I will hand it over to sir. You can take up.
We will continue to discuss together, Ravi. So sir, at this stage, how many of you believe that it's an ARDS on the basis of the data we have given? Dramatic response we have seen, shadows. You believe it's ARDS? Sir, कुछ chocolate दे दे? Because we had chocolates for you. And how many of you believe? And how many of you believe it's not an ARDS? Dr. Sharma, if Dr. Suresh को भी chocolate दे दे. No, there is a reason why I am telling you, because we were never clear in this case.
Manish, I feel in this case, there will be this combination of some element of fluid overload,
Yes.
some element of
Thank you, sir.
infection,
That is what we.
and middle cardiac pulmonary demand. You are having metabolic acidosis.
Yeah, we gave 2 chocolate to Dr. Sharma because he gave us 3 chocolates. to Dr.
Metabolic
Sharma.
acidosis can cause the depression of cardiac function. There is some element of cardiac pulmonary demand in this case.
No, I agree with you, sir. It was not easy.
Because they have shown you IVC बढ़िया से
Cardiac function is not
missing heart दिखाया, which says कि
No, that was the initial one. That was the initial one. During the re-intubation, that should be screened. No doubt on the basis of X-ray test and ABG, this is, you can say the ARDS. Maybe the cardiogenic or
I
non-cardiogenic.
agree with you,
But I want to know what was the bone marrow response during this whole event.
What was, sorry?
Bone marrow response, whether
Bone response.
leukopenia and this.
The bone marrow, it was nothing like it was.
Leukocytosis,
No, it was.
leukopenia, like raceoimers.
No, you're right, you're right. In fact, this is an interesting finding. Initially, the patient TLC was operated around 4,000 to 5,000. It was not leukocytosis out of the proportion, which again goes in favor of viral, as you said.
That's right. If it is around 4,000, so it may be the suggestive of the viral pneumonia, which patient have got from the environment of this hospital environment.
Agreed. Completely agreed. No, that always was there in the ground. The reason I'm sharing with you, like here, all astute physicians, even there is a difference of opinion. Same happens when you are actually dealing the patient bedside. Just imagine the people who are resuscitating, they are the people with the least of experience and guidance. So the same confusion had.
Chocolate.
Dr. Devendra, chocolate, yes. No. This is actually we had it for you.
Yeah, actually I'm
Got a
diabetic.
bag full of chocolates. Anybody talking get a chocolate today?
Yes. Yes, sir. And I encourage people from behind as well.
So everybody has to participate.
Yes, everybody has
Get
to
a
participate.
chocolate.
We had a quiz also in the last. So the point here was that even we were confused because if it is ARDS, it's very clear you have to prone them. There is no dilemma, there is no doubt, right? But the question comes, had it not been ARDS, how many of you would consider proning as an evidence-based practice? We were confused because ProSEPA is very clear, the trial which we are talking about, which has taken as a benchmark by Durin in 2013. For ARDS, the guidelines are clear. But for non-ARDS based pulmonary edema, the guidelines are still not established. So we were in a fix in this situation. And obviously this is, we presume to begin with, as a rescue therapy, we are dealing with ARDS. And this was the paper just for the students in the behind. If you are dealing with the ARDS, which is severe variety with a PF ratio of less than 150, these patients, they need to be prone on the basis of this trial. And this is one trial which has given you a clear mortality benefit. 50% of the cases who has received the proning, they survive. There is absolute mortality benefit by 50%. Very big mortality benefit. And that too, there is no pharmacy which is involved in this case. Just the physiological change which you are experiencing, right? Now, this is how typically the ARDS CT looks around. If you see the one which is there, the dependent area, is very dense, less irritated, almost gasless. We are not interested in this area because this is not recruitable. They are not going to work. Then there is an intermediate area which is going to be a recruitable part. This is where we want to work to improve the V/Q ratio. And then the one which is there in the ventral area, the anterior part of the chest, which actually suffers because of tidal volume, which leads to the regional hyperinflation. Because if you give them conventional tidal volume, nothing goes to the basis, everything goes to the area which is in baby lung, right? So this is how a typical ARDS patient who is having a CT needs to look around. Can you go next? Now when you do a proning, how does it function? Anybody who would like to volunteer? Chocolates for you guys? Yeah, please.
Basically increases the lung volume and
Very
it
good.
also allows the redistribution of air and blood to vital.
Very good. So which volume increases, my dear friend? It typically improves what kind of volumes of the lung? FRC. Yeah, very good. Chocolate for it. Thank you. Clapping, please. The point, as you have said, it improves the lung volume. But how does it happen? When you are in a supine position, the heart has to press over the lung, right? If you can see, this is the heart which is pressing over to the lung, which causes compressive atelectasis. Also, when the patient is in a supine position, the abdominal organs, they are going to push the basal part of the diaphragm, which lead to the compressive atelectasis. Now, when you are going to make them prone, you are going to offload the lungs. And that is why it improves, the ventilation to that area of the lung, which is leading to compressive atelectasis because of the heart. Not only this, when you make them prone, even abdominal organs, they move away. Now this is basically a hypothesis, proven hypothesis, not a hypothesis, a proven theory behind the improvement in ventilation and the perfusion mismatch which typically happens in a patient with ARDS, right? Can you go next? Yeah. So when you make the patient from supine to prone, it causes recruitment of the dorsal part of the lung, right? Now when your dorsal part of the lung is going to get better, it is going to homogenize the lung. Because now the lungs which are there in the bases, the dorsal part, they also start participating. So the tidal volume which was initially leading to regional hyperinflation lead to isoinflation, which you can see in the diagram as well. And obviously if you have homogenized lung, and ARDS is a heterogeneous disease, right? So when it leads to the homogenization of your lung, it causes improvement in your V/Q mismatch. And not only this, the most important advantage, lung injury. The lung injury is going to be minimized because now the stress and the strain which happens to the healthy lung is going to be now given to the diseased lung as well. Right? Next, please. This is something which I encourage each one of you, especially the postgraduate. The person on the left is Claude Gore, who has given this ProSEPA trial. This is available on YouTube. Please go through this video. He has explained that how to use proning for your ARDS patient. Beautifully given the explanation the indications and the contraindication as well. So as we have said, Dr. Sharma, you're very much right. We thought ARDS, hydrostatic, cardiogenic, all these three things could have happened, and possibly we were also thinking like the overlap syndrome. Now the question comes, what in case if it is hydrostatic? Will you do the proning in that situation? Let's say 1 school of thought, because airway pressures were not elevated. Compliance were 30 to 40 mils centimeter of water. Will you still recommend proning in these cases? Let's say somebody is, because by definition it was not clearly an ARDS. So what is your take, sir? Please.
What is the harm?
Very good, sir. I love this answer because this is what even we thought.
IBC.
But evidence.
IBC.
IBC, sorry.
IBC should be checked whether full compression or
No,
not.
IBC checked. IBC was regularly assessed, Dr. Devinder. It was never bloated. It was never.
Whether lungs were wet or dry.
The lungs were wet. I had shown you. We have similar kind of, the lung ultrasound.
What was the BP, whether we can
Hemodynamically
diuretics or
stable.
not?
Very good. So patient was hemodynamically stable during this phase on low dose of
So
vasopressors.
diuretics should be.
We tried diuretics, but it was not of great respite in this case.
Second thing, hypoalbuminemia to me because in the presence of hypoalbuminemia, even diuretics doesn't work.
Yeah, very important diabetic resistance, very important point which Dr. Devinder has raised. If you have hypoalbuminemia, even if you give diuretics, you will have diabetic resistance. But, no, but hypoalbuminemia is a valid point. When you are giving 30 mils per kg, it will lead to on-body pressure dilation. I agree with you. So your point was very valid, sir. You said that what is the harm? How many of you believe that there is no harm, so should we prone the patient with hydrostatic pulmonary edema? How many of us will believe? Because if you believe, then you will have to allow me in ICU when I'm going to do it.
There are certain things which one need to be careful while telling the patient prone, but definitely improves the respiratory function and cardiac function both.
Yes.
Reduces afterload, reduces the cardiac function also, reduces cardiac pulmonary mental health, and you have to take pressure points, pressure injuries, all this you have to take care.
Unless there is pulmonary hypertension.
So there is no harm, but you need to take precaution while telling the patient pressure injuries.
Studies for
Yeah, now this is very important, sir. So can you just go to the next slide? So what we did, because we want evidence for whatever we are doing, we did as a rescue. But when we went into the literature, way back in 2000, Nakos has given a paper, a beautiful paper, where he has given 4 subset of patients with hypoxemic respiratory failure, and they came with the conclusion. Can you go next, please? And he came with the conclusion that the patient who are having pulmonary edema in early ARDS and even hydrostatic pulmonary edema, HPE, predicts a beneficial effects of the prone position on gas exchange. Mortality benefit he has not spoken, but gas exchange benefits they have established. Next, please. However, if you are having a late ARDS presentation, obviously proning is not going to help. So this is one paper in 2000 which came as a rescue to what we did in our ICU. It came as a rescue. Can you go next, please? Now, point which I wanted to impress upon, that people have done all this kind of therapy as a rescue strategy, not as a first line of a treatment which ARDS has established for us. Even to the extent where the patient post-cardiac surgery has gone into a flash pulmonary edema and not responding to the conventional mechanical ventilation post-cardiac surgery. Even in that cases, they have done the proning and they have been able to salvage the case. So starting from established ARDS to the non-ARDS, possibly hydrostatic pulmonary edema, and even in post-cardiac surgery, flash pulmonary edema.
But you must remember, this is a single case report.
Agreed, sir. Agreed. The reason is to stretch our conventional thinking pattern. We are not saying it has to be done routinely for your patients. We are not saying, because in that case, the patient was getting sicker and sicker, and the only therapy which was available for us was proning, because ECMO we are not having. So venovenous ECMO is not a standard of care in
I'm
our
not talking about ARDS.
Yeah, please, sir.
I'm talking about this post-cardiac patient.
No, not as a routine, sir. Not as a routine. Sir, I'm talking about refractory hypoxemia. If it happens, how you will come out as a risk. That is what I'm trying to do. Next, please. And this is important paper which they said, which has recently got published in 2022, Dr. Sharma, and this is the Lancet, very popular study. What they said, even if cardiogenic pulmonary edema is there, and if you have high airway pressure which are associated with mechanical ventilation, it does induces really ventilator-induced lung injury and also increases the mortality. So if you have a cardiogenic pulmonary edema or a hydrostatic pulmonary edema, and if you find airway pressures are on the high side, proning is still recommended in them on the basis of this paper, right? So the carry home message which we want to give, ARDS now, it's a very common diagnosis in our ICU. One, because of awareness, which we have established, and secondly, because the diagnostic criteria is very simple, especially in the 2023 modification, right? Severe ARDS, like in this case, which we are thinking, carries a very high mortality. 40% of the cases they are going to die. And that's why you should treat as a medical emergency like ACS, septic shock. This is also medical emergency. This is what is our plea, right? And that's why you should give them lung protective ventilation and proning as early as possible. Low tidal volume, there is no confusion, has to be given for all patients, irrespective of ARDS versus non-ARDS. It's proven beyond a doubt. What is important, which we discovered in this case, which I think is an insight, even if you have an ARDS, which is there in ICU, you can have confounding variables in the form of left atrial hypertension leading to cardiogenic edema if the patient has coexisting disease like heart dysfunction. And when you're giving them fluid therapy, because the patient is also having a septic shock, you can expect wetness of the lung because of HPE, hydrostatic pulmonary edema. Because it's not like that the patient with heart dysfunction, they cannot have ARDS. In fact, they are likely to have more commonly ARDS, right? Prone ventilation is an effective strategy beyond doubt, and mortality benefit in ARDS proven beyond any other doubt. Prone ventilation has plenty of benefits, including oxygenation, ventilation, minimizing the lung injury, which is today the call of the 2024 is, and obviously mods and proven mortality benefits. We have seen in ProServe trial, 50% of the mortality benefit has been seen. What is the conclusion point? Prone ventilation is yet not the standard of care in patients with CPE and hydrostatic edema. However, you can use it as a rescue therapy if your patient is not responding. With this, we would like to close this presentation. It's a quiz time for you guys. Please participate. Dr. Vikram sir, I need your one answer, maybe in this case. So, Ankit, can you just take the quiz? Because you make this quiz.
So with the solve this effort, I'm going to start the quiz time. So she is a 56-year-old patient presented with UTI septic shock, developed hypoxia on third day. Chest X-ray shows diffuse infiltrates and 2D echo shows normal cardiac function. Patient was intubated and put on ventilator. Sats were 90% on a 502 of 0.7. What should be the next best step in management of hypoxia? So options are in front of you.
Tidal volume and
What do you think?
C option.
patient should be hyperventilated.
Very good, sir, because I but this is not Anybody else? D. D is what?
Patient should be hyperventilated.
Very good. Is Dr. Derinder कोई chocolate?
Yeah, मिल गई मैं I'm diabetic है काफी है यार.
No, sir. Please enjoy, sir. We are rich people. The reason why, because if we are endorsing proning, doesn't mean every patient has to prone without even optimization of your ventilation settings. Please don't get misjudged by the proning. We are saying you still have to optimize your ventilation settings, give them a reasonable PEEP, and make sure that the PF ratio is less than 150 before you are going to prone. Mortality benefit is only with the patient with moderately severe ARDS. Right, next.
बेसिकली इसको तो उस तरह से भी हम एक्सप्लेन कर सकते हैं कि this patient due to this sepsis है ना, this will be in metabolic acidosis, and whenever patient is not intubated, that is trying to wash out to this carbon dioxide to maintain the pH. और हमने नॉर्मल कंडीशन, हमने जो नॉर्मल वैल्यूज के ऊपर अगर उसको वेंटिलेट किया तो दैट विल रिटेन द कार्बन डाइऑक्साइड आल्सो एंड फर्दर लैंड अप इन द metabolic acidosis as well as the respiratory acidosis है ना. तो we should hyperventilate this
You should,
patient.
yes, I agree with you.
उसमें आपने जो प्रोनिंग की बात करी वहाँ पे मतलब जब पीजीज बैठे हुए तो सिडेट पैरालाइज का जो रोल होता है उसको भी आपका
Yeah, this is important. Actually, this is important. Dr. Derinder has.
So if this is important for you guys, if you find that patient continues to be hypoxemic, let's say that you are giving 100% F5 and you still see that patient is not maintaining saturation, first common things first. Make sure if the patient is tubed, the tube is in the right position, endotracheal tube. Common reasons are endobronchial intubations, sometimes pneumothorax, especially when you are planning to give PEEP. So please make sure that these two basic things have been ruled out. Second thing, as per Accurus trial, if your patient continues to be hypoxemic, you should deeply sedate
and even paralyzed with cis-atracurate, because cis-atra is not available. Accurus is endorsed atracurate therapy, which has to be given for 24 to 48 hours, not beyond that, right? Because the common reasons for the patient to have hypoxemia is when they stack onto the ventilator, which is ventilator patient dysentery, which call them as. So if they are not coordinating well with the machine, you can anticipate one lung injury and plus destabilization of your oxygenation status in this. So deeply sedate and paralyzed, right?
So you will do C, that's all right. But
Sorry, sir?
You will do C,
Yeah.
that's all right, accepted. But
Perfect.
you can also do A and B.
Change the antibiotics. Yeah. Yeah. Sir, that is no. He's right. Actually, you're right.
A and B also you
No,
need
you're
to do
right.
simultaneously.
Sir, you are a pediatrician.
No, I am a plastic surgeon.
Oh, plastic surgeon. Okay, sorry, sir, I'm meeting you for the first time. Surgeon takes care of antibiotics.
D and E agree.
Yeah.
D and E, I agree.
Uh-huh.
Cannot come as an answer. But A and B still can come.
Okay, very good, sir. I don't know, maybe Dr. Devendra is a better person to answer. Do you think nebulization is going to help if there is no basic
Steroid is going to help.
There is no.
Steroid is going to help.
No, sir, I just wanted to know first about bronchodilators. Do you think it should be given?
Basically, other than this bronchospasm, we tried with diuretics or we prefer to give if there is some cardiogenic pulmonary edema, because secondarily there can be from the bronchospasm. If there is infiltrates in the lung, secondary bronchospasm can be there. Otherwise,
If bronchospasm is not there, should be
there is no infiltrate, there is no pulmonary cardiodema, no.
Okay. Actually, we were not anticipating any. We have not actually realized that this patient was having spasm on the basis of daily pressure. So that is why we are not given. But in case if you have bronchial hyperactivity, which is reflected by on the ventilation, you can easily see that your respiratory waveform is not returning to the baseline. Auto beep is there. Typically, ARDS patient they never have spasm as a reason for their ventilation. Generally, they have relatively fast time constant, so they empty very fast. So this was generally bronchodilator therapy. As per the trials, is being discouraged in ARDS. Secondly, sir, you said about antibiotics. Yes, sir, we did change the antibiotics. I
You have to change.
Yeah.
Because you are upgrading. Yeah, I mean, there's a guy who is on UTI in septic shock, goes on ventilator.
Yeah.
You don't upgrade the antibiotic.
No, you're right.
It will not be accepted.
Antibiotics were already, you're right. That's why optimization of antibiotics has to be taken care of. The question here was that what is the next best
Yeah,
step?
that's
Basically,
what
patient
From that
was,
segment, yeah.
basically patient was intubated on the third day. At this time, we should have the culture report by this time.
Yeah.
We should.
Once patient is pneumonitis with septic shock, you have to start the steroid first.
Steroid?
Yeah.
In steroid, you should give in a stress doses, which is around 200 milligram of hydrocortisone per day. But hydrocortisone is not going to change the game of ARDS patient. In septic shock, you should give them stress doses. We call them as critical illness related circulatory insufficiency. So we give them 200 to 300 milligram of hydrocortisone. We are talking about here, patient is pertaining to refractory hypoxemia. Hypoxemia in this case. So in that situation, we are talking. Anyway, sir, we will not
All the answers to correct answers at some point or the other.
That's why I said, what is the next best step?
You also give chocolate to everybody.
Exactly. What is next? हाँ. अच्छा ये पीचेस बताएंगे. What is the hallmark for तूने बता. अच्छा ये पीचेस बताएंगे. What is the hallmark for तूने बता दिया कोई और बताएगा. What is the hallmark for ARDS on chest X-ray? अच्छा particular. Come here, please take the chocolate. Take your chocolate. What's your name, beta? I think you are from United. Thank you. Ground class of pastry. What is next? What is the which following intervention is a cornerstone of ARDS management?
नहीं सर क्वेश्चन वाला
खत्म नहीं होगा खाना भी है पीछे
सर ये नहीं बोल रहा
अभी सब
पहले
चलेगा
वाला
नहीं
क्वेश्चन है ना इसके पहले वाला जो क्वेश्चन सीटी पे आएगा ग्राउंड पे
नहीं
पायलट
ग्राउंड क्लासिंग नो यू आर राइट ग्राउंड क्लासिंग इज टिपिकली वी यूज अच्छा ये हम बाद में डिस्कस करेंगे मैंने चॉकलेट वापस हो जाएगी ये बाद में डिस्कस कर लेंगे अच्छा इसका क्या आंसर है यस प्लीज It's very good. Come here, take the chocolate. Very good. So low tidal volume ventilation is meant for all. Anji, which of the following is not the criteria for the diagnosis of ARDS? Acute onset, hypoxemia, PF ratio less than 300, evidence of left atrial hypertension, and bilateral basically suggested. अच्छा, come here. chocolate तो ले ले यार, ये कौन सी डांट पड़ रही है? So evidence. So अगर evidence of right atrial hypertension, it means cardiogenic. Okay. Which of the following is often used to evaluate the severity of ARDS?
PaO2 FiO2 ratio.
Come निखिल, तू तो ARDS expert है. अच्छा ये important है. Who next? Which is true and false? ARDS can only occur in patient with pre-existing lung disease. False. Right? Was not simple subject. Akhilesh.
Multiple people have given the right answer. You can have these.
So no problem. Sir, I have to give something extra because Dr. Sharma asked me कि critical care यार अच्छे से होना चाहिए. Chocolate ही हो जाए. Mechanical ventilation is no. Go previous question. Mechanical ventilation is often required in the management of severe ARDS. True or false? Severe ARDS. True. Dr. Suresh. Drone ventilation can improve oxygenation and mortality in patients with ARDS. ये इसी चीज के लिए भैया. The Berlin definition is the current standard diagnostic criteria for ARDS. Who said true? तूने बोल दिया और आज काम सोनम ठीक है. ARDS primarily is a hydrostatic pulmonary edema with diffuse infiltrates. What do you think? It's predominantly a hydrostatic pulmonary edema with diffuse infiltrates. False? Ranju, come. Very good. It's not hydrostatic. Hydrostatic means fluid balloon. Next, please. A patient on ventilator is being decided to be prone, and you are asking my treating nurse, what should we do about the patient RT feed? My patient is on prone. Should I feed him or should not? What would be your answer?
Continue.
Consent.
D.
No change in feed.
Sir, Dr. Return, please, what is your take?
Leaving it alone. Should continue.
Yes, thank you, sir. So this is the answer. So you should continue. We just wanted the gastric residual volume, RT aspirate. If it is not, no, sir. This is a matter of respect, please. Okay. Which is an absolute contraindication for chronic. By the way, there are no absolute contraindication. Very limited contraindication for chronic. But they are sorry. D. Very good. So D is by unstable spine fracture. Okay. Thank you for.